Welcome to Health in Today's Woman. My name is Dr. Kelly Williams, and I'm the host of this show. Tonight we're going to take on a topic that we have been discussing in the media a lot recently. It's the whole idea of the Tennessee Health Report Card. It was a study that came out that would study the data from 2004 to 2009 about information about health care in the state of Tennessee. Now, what you've heard mostly is complaints about how poorly we did. Well, tonight we're going to take a focus and a look further into this study and try to develop some positive answers and some solutions to some of our shortcomings and also some positives about what we're doing right here in the state of Tennessee. To help me better understand and to delve into this issue, I have invited Dr. Connie Graves, who is a high-risk specialist with Tennessee Maternal Fetal Medicine Associates, and Dr. Barry Jarnigin, who is the medical director of the Center for Pelvic Health in Cool Springs, and who is also on St. Thomas's Hospital group. I want to say, first of all, thank you all for being willing to be here tonight. And I want to kind of talk about this. This is such an interesting study because it really talks a lot about what we're doing in the state of Tennessee, both good and bad. And as always in my show, I try to focus not only on the good things, not only on the bad things, but really try to look at both and also try to find good solutions. Now, I want to start off with one of the things that I think is very important about the study. The study divided things up based on different parts of health. It dealt with preventable causes of health problems. It dealt with modifiable behaviors. It dealt with deaths. All these things are part of the study. And the way they did it was they gave grades to these different aspects based on ethnic groups. Now, what's interesting about this study is that the grades were just decided on by a group of researchers at Vanderbilt to put this study together. So we're going to look at that. Tonight, though, I want to start off by just talking about the first part of the study, which is smoking. Now, it's one of the things that I think is very interesting that's going on in Tennessee right now. We are seeing some decline in smoking rates, but one of the things I think is interesting is we're still seeing a fair number of people 18 plus years that are smoking in this state. So we have a billboard here that I want to show you, the first billboard of who we have. But you can see it's done by the different ethnic groups as well as everybody. And you can notice, interestingly enough, that we got a D. The African American community actually has seen a major decline in the number of smokers that are going on. My question to both of y'all is to start off is, what are we doing right here? We're doing something right in the African American community because we're seeing a decline of almost 8% over those 5 years. Kind of, what are we doing right in that community that's helping us to see a decline?
Well, I think in particular with African American women, smoking has not ever been as big of a focus as it has been in the Caucasian community.
That's a good point.
Some of that may be because just of some cultural things and surrounding smoking. I will say that after the age of 25, it is interesting because more African American women will pick up smoking and will become smokers for later on in life. I think that what we're doing well in the African American community is talking about tobacco use, and I think with our African American girls, there's a much stronger focus on education and things of that nature than there may be in other communities.
And what do we need to be doing? I mentioned this to you, Barry. What do we need to be doing in all communities? Because I think it's interesting. We've seen a decline in the African American community. We need to take the positives from that and add it to everything. What do you say about that?
I was about to say the same thing, is that we need to take what's working well in that population and expand it across all populations, because it's clearly a problem across all populations. And so taking what works and expanding on that is critical. However, I do want to point out, I mean, even though they gave D reports, I mean, that seeing a 5% decline, 5+% decline in a state that is historically a tobacco state is really pretty good, because a lot of this, as Connie pointed out, is changing culture and educating, and it takes a while to turn the big ship. So when you consider that we were a tobacco state where we produce tobacco in our backyard, and we're now converting and we're reducing the smoking rate by over 5% over that period of time, that really reflects that the state's really working pretty hard at getting that accomplished.
And one of the things I noticed when I was doing some research on this study, we've focused a lot in this state, a positive, on smoking. We've seen new laws that are requiring people that they can't smoke in certain areas. We're seeing a lot of positives going on in this community. I mean, do y'all agree with that?
I agree. The other thing I was going to say is in the Caucasian community, smoking is used frequently by women for weight control.
That's a good point.
And so, and the African American community, in our communities, being thin is not always considered an attractive trait. So for a lot of those girls who take up smoking in order to make sure that they don't eat anything, I think that may be another place where we can make some emphasis and some change. I think recently there's been a lot of emphasis in the news media about that focus on being rail thin and how that's really not a healthy image. So I think that as we go forward, those are some of the things we may want to look at, especially when you're looking at smoking in women.
And how do we as physicians, because this is one of the things I really want to bring out in this show, is physicians need to be a part of the answer. How do we as physicians address this issue? Any ideas?
Well, I think one of the first things is when you see your patients that you address it with them. Often I think we as physicians like to avoid social issues, lifestyle factors, number of sexual partners, whether you drink or whether you smoke. So we ask these very cursory on the top questions. And the patient says yes, we write down yes, and then we keep on going, hoping that we don't have to address it. So I think the first thing is you have to address it with the patient. The second thing is learning what makes the patient, what makes the patient tick. I think for women, one of the things I say to young women is that she says, smoking makes you wrinkle. And to
that's
them,
that's a good point.
And often I think, especially for young women, there's not this thought of what's going to happen long term. And lung cancer and heart disease are something that my mother and my grandmother have. So, but if you start telling them things that will appeal to them at that point in their lives, that will often get their attention.
All right, we've had a great discussion. I'm going to get back to you, Barry, as we come back. We're going to take this break right now. We're going to come back and talk a little bit more about smoking, and we're going to look at smoking and pregnancy. We'll be right back after these messages.
African American, but 52% of us are overweight.
Well, and that's the other thing we're going to mention is what's wrong there, because I think that's a good point. And you brought up some excellent points that we can take back later and say, okay, you're right, we're seeing this, but now we're starting to see the opposite of the obesity problem, which we'll talk about in the next show.
We're fat, but to us, being rail thin is not an attractive trait. But a lot of, especially when I was in college, a lot of my Caucasian friends smoked, and that's the major reason they smoked, because they wouldn't eat.
You're exactly right. You're exactly right. And I appreciate you bringing that up, because I wouldn't have thought of that.
The next one. Welcome back to Health in Today's Woman. Tonight we're discussing the Tennessee Health Report Card. It's a study that was brought out by Vanderbilt University, Meharry Medical College, and the Department of Health for the state of Tennessee. What this study does is it looks at all the different aspects of healthcare in the state of Tennessee and grades them. So we're taking it apart today and looking for some positive solutions to some of the things that they say we're not doing so well in the state of Tennessee. In the last segment, we talked a little bit about smoking, and we're going to continue with that. And this is, I want to talk a little bit, one of the positives in this study is that we're seeing the decreasing number of patients who are pregnant who are smoking. And I think that's a huge issue. And Connie, I want you to ask you two questions here. One of the things is, I want you to go through a little bit about what some of the effects of smoking are in pregnancy. And then I want you to address, what are we doing right? Because obviously we're doing something, because we're seeing a decrease in the number. It's a huge issue.
Well, smoking is probably one of the largest modifiable risk factors that one can do in pregnancy. And it's very important to understand that when you're talking about pregnancy and modifying your risk, that the stopping smoking is the biggest bang for the buck.
Right.
Smoking is associated with an increased risk of preterm labor, an increased risk of preterm rupture of the membranes, an increased risk that your placenta can separate and just suddenly, and that can cause harm for you and possibly death for the baby. An increased risk that your water could just break. As there's an increased risk of low birth weight, or what we call intrauterine growth retardation, where the baby doesn't grow well.
Right.
In fact, recent studies have denoted that the baby is about 250 grams smaller in women, in the babies of mothers who smoke. So that's a little bit over half a pound.
One thing I want to mention here, because I want to bring this up, because I think that's important she just brought that up, because there are people who think that if I smoke, I'm going to make my baby smaller.
That's correct.
And that's something we need to address, because that's a huge issue. And I've heard this before. It's something that people don't realize. That's not a good thing.
No, it's not a good thing to make your baby smaller, and you're going to make your baby smaller in the way that the baby doesn't grow, that the head may still grow, but the baby's body doesn't grow. So the baby actually has high blood pressure inside your uterus and has some other things going on that are definitely not good for the baby. In addition to that, after the baby's born, babies of mothers who smoke have a higher incidence of sudden infant death syndrome.
Right.
So, you know, given all those factors, we know the American College of Obstetrics and Gynecology started a major push for smoking cessation in pregnancy.
Okay.
And they started providing physicians and midwives and healthcare and other people who care for women who are pregnant with tools to actually discuss smoking with their patients. So I think that's what we're doing right, is the fact that we now recognize this as one of the major modifiable risk factors, and it's a risk factor that should be modified during pregnancy, not only for the time during pregnancy, but for the neonate after the baby, after birth.
And the way I explain this to patients is what gives you the high in smoking is constriction of blood vessels. And what you don't realize is the placenta is nothing but a big bag of blood vessels. So when you get that constriction, you're going to cause these problems, because that's what gives the highs. The constriction of blood vessels in the brain is what gives you the high. Well, guess what? It's not just the brain that gets constriction, it's everywhere else.
That is exactly correct.
Now, the other thing I want to look at here, because this is something we did not see a decline in, I want to discuss this with both of y'all, and that is the issues of STDs. In fact, we've seen an increase in the risk of STDs in this community in Tennessee. And we're basically seeing it in two major entities. One is chlamydia, the second one is syphilis. What are we doing wrong here? I mean, you know, I think that's something that we have to address. Barry, do you have any comments to this?
Well, I think simply put, we're not educating the population. I mean, I was sitting here thinking as y'all were talking about smoking, they're talking about smoking in the classroom in schools across the state of Tennessee. So by the time that those ladies get to their doctor, they've heard it several times before.
Right.
We're not quite as open about talking about sexually transmitted diseases in the classroom. And so therefore, if we talk about it, and Connie's right, there's a lot of physicians who are not comfortable talking about those things. So if you're not asking the questions, you're not getting the answers. And so they're not hearing it in the school systems like they are on smoking and other things that are easy hits.
Right.
And they're not hearing it from their doctors because their doctors are uncomfortable talking about it. And so it's a lack of education. And
we're seeing a major race in the African American community. And my question of this is not, you know, it seems like that so much of this study, and so much of what I've heard in the media seems to beat up on the African American community. My question is, how do we communicate differently with the African American community? Because the question is, what works in the Caucasian community may not be the same thing that's going to work in the African American community. What works in the African American community may not work in the white community. What's your comment to that?
Well, I think there's a couple of things. When you look at the increase in sexually transmitted diseases, there are increases in pockets. And I find it interesting that one of the pockets actually was Belle Meade in Nashville for syphilis, which I found interesting. I think that one of the issues is how we view sex in general. You know, if sex is unplanned, if it's not something that a good, quote, good girl planned to do and it just happened, that's okay. But when a good girl doesn't plan to have sex, and so therefore there's no response, often we don't take responsibility. It actually translates over to us for unplanned pregnancy as well. You know, I didn't intend that to happen, for that to happen. How many times have you heard that from your patient?
Yeah, sure.
And so I think in the African American community, we have to actually empower women and say, you know, it's okay, number one, to have sex. And if you plan to have sex, then, you know, you need to be empowered to ask your partner to protect you and to protect himself by using condoms or certain other things so that you don't get a sexually transmitted disease.
I think it's really important what you mentioned, because a lot of this study was done, you know, although we're talking about a whole state, we're going to discuss this in a future show, is to talk about, it's really about individual areas. It's interesting that Belle Meade is high, and you know, it's not just about the whole state of Tennessee. It's really narrowing into certain areas, isn't it?
That's exactly right. And what may work in one area, like you just said, may not work in another area. You know, again, I think that same thing. It's okay to have, you know, if something happens and the woman gets swept away, it's okay. But that lack of planning. But if you plan for it, then that's not okay. And if we have to change the attitude, if we're going to change some of the issues that we have as far as sexually transmitted disease.
And I think we need to get comfortable talking about sex, just like we're comfortable talking about tobacco and obesity and every other thing. And physicians are not comfortable talking about it. And I think patients, you know, if they have that unplanned event and then they go, uh-oh, but they're not willing to go to their doctor and talk about it. And so it permeates along. So we have to get an open dialogue going.
And I think doctors and healthcare providers have to change know their prejudices. One of the
don't agree
issues
with that.
is that, if you think you have a married patient who lives in Belmead, then maybe I don't check her for sexually transmitted disease because she's married and she wouldn't have sexually transmitted disease. And so therefore that I didn't even screen her for that, and so now she comes back in and she has this disease process. So doctors, I think, have a lot of biases and prejudices that we also have to overcome in order to provide our patients with the appropriate care.
This has been a great discussion. And like I said earlier, I really do think that this is something that physicians need to check into and really make a difference. And we've had some great discussion. We'll be right back after these messages. We'll continue to look at the things that we're facing here in the state of Tennessee. We'll be right back.
Read the report.
Welcome back to Health in Today's Woman. Tonight we're having a great discussion about some of the health problems here in the state of Tennessee. We're looking at the Tennessee Health Report Card. In our first segment we talked about smoking. In our last segment we talked a little bit about some of the preventable causes of disease. In this segment I want to look at some of the preventable causes of death. And I want to start with talking about cervical cancer. The study shows that we have had a decrease in cervical cancer deaths since 2004. We actually have a billboard of this, and I want to show it to you right now. We have seen a decline in the number of cervical deaths per 100,000 women. Again, we've had this discussion. Although we've seen a little bit of a decline, we're also seeing a grade D and a grade F, which is what we hear all the way through the media. We're going to discuss this in a little bit more detail to figure out not only just what the D and the F mean, but what we're doing as positives and how to address those solutions. Now, the thing that I want to start with is I think it's the most important thing that we can address. In my opinion, there's no reason to die of cervical cancer. We have got a proven test that for the vast majority of patients will solve this problem before they ever get there. I'm a big believer in the fact that Papa Nicolau, the man who developed the pap smear, has saved more women's lives than probably anybody else. I mean, it's incredible, the thing. It's the only test that we have out there that's proven scientifically to prevent cancer. So why are we seeing cancer deaths? Why are we not seeing people getting pap smears? Any comments to that, Barry?
I think there's a little bit of mystery involved because they've done studies to show that even when you offer pap smears for free, there's a certain segment of the population that don't go in to get them. And so there is a real mystery, and part of that probably has to do with uncomfortableness and they just don't want to go do it. But I think there is some issue of, I mean, even if we hand them out for free, people are still not doing it, even though we know, as you said, that it's a proven way of preventing cancer.
And that's the only thing, and I've told this before to a number of people, honestly, it's the only test. We have mammograms, colonoscopy, any other screening test. Nothing's been proven scientifically to prevent cancer except the pap smear. That's an incredible statement, but it's a true statement. Connie, what do you think?
I think that number one, that again, it goes back to our kind of belief system and a lot of our cultural issues of sex, women's female examination, coming in to expose your most intimate areas, things of that nature. A lot of women are still very uncomfortable with that. Often I think some of it's an access issue, some of it is an education issue, and some of it is just a time issue. I think a lot of women these days are busy, and it takes time to make an appointment, go in to see the physician, sit there for an hour, and get these tests done.
Now we're looking here, this is the women that 18 plus have had pap smears in the last 3 years. And you can see, we got a C, which isn't bad, but we're starting to see a decline in this. And I think that's really important, that it's not as important what the numbers are, it's important we're seeing a decline. And I think that's an important issue, that why are we seeing that? This is a test that we know is definitely a positive. Now I want to show something else because I want to kind of draw a little bit of attention to this. We have a billboard here that's on breast cancer death. I want to put this up. Now, the reason I want to show you this isn't because of the breast cancer deaths. It's because of the fact you'll notice that in the last billboard we had up on cervical cancer, we had 3 deaths per 100,000 women. We have 36 per 100,000 women with breast cancer. Cervical cancer used to be one of the #1 killers of women in this country. The pap smear is what's changed this. That's why my big argument is, what do we need to do to get people to realize this is a really important test? I mean, 36 per 10,000 women, for 100,000 women, down to 3 per 100,000 women, that's the pap smear. I mean, there may be arguments against that, but the honest truth is, that's the pap smear. And we have a screening test for breast cancer, but we're still seeing such high rates of breast cancer death. What do you think, Connie?
Well, I think that in many communities, In the African American community, not all cancer, as we know, is created equal. So even when you notice that more African American women get Pap smears than their Caucasian counterparts, they're more likely to die from cervical cancer deaths. That may be because the cervical cancer that they get is a different variant, is a variant
Right.
of what is the normal everyday squamous cell cervical cancer. We also know that cofactors that are involved in the progression of cancer disease, including obesity and smoking, especially with cervical cancer, so that may be an issue as well. With breast cancer, we definitely know that breast cancer in African American women occurs earlier,
Yes,
can
it
be more
does.
aggressive,
It does.
and
It's-
it may not always respond to the treatments that have been so well researched in other populations.
And that's one of the things that the study points out specifically, is that one of the reasons you have a higher rate of breast cancer death in African Americans is because it's a different cancer. It's a much more aggressive cancer, and something that I want to make sure we point at, because that's something that the study points out, that there is a higher rate of breast cancer death among African American women, probably not because of mammography, but because of more aggressive deaths, more aggressive cancers. What do you have to say, Barry? I mean, we want to leave you out of this either.
Well, I think there's the ability of denial in breast cancer, which I have seen and talked to patients about, where they may feel a lump and it's almost like they'd rather stick their head in the sand and pretend it's going to go away rather than face it and go in and be seen. And so I think it is cultural to some degree, and I think there is, but denial is a powerful tool. And I think part of that is education of we can help if we catch it early. And so, and I think there's a lot of fear of, if I get diagnosed with the big C word, I'm going to die.
Right.
And so why bother? And so they choose to deny and hope that it goes away on its own, which on the surface seems illogical, but in their minds it's the only chance they have. And so we got to get the word out that that it is treatable, that people who are getting treatment can be cured, and give patients hope that if they feel something, they need to get in and be seen.
We've had some great discussions, and one of the things I always say about the show that's so important is we don't want to just talk about the negatives. We want to find solutions for those negatives, and I think we've done a good job of that tonight. We'll be right back after these messages where we'll wrap up the show. Welcome back to Health in Today's Woman. We want to say thank you to Dr. Barry Jarnigin and Dr. Connie Graves for being willing to come on tonight to talk about some of the issues facing healthcare in the state of Tennessee. We've had a great discussion, and we're going to continue the discussion in our next show. Thank you, and we hope to see you next week.